Good morning, good afternoon, good evening. It's 3 o'clock in Brazil, 1 o'clock in New York City. Hello, everyone, and thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfati, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Juan Pablo Munoz, Dr. Anna Falkowski, and Dr. Mark Cresswell. This session will focus on sports imaging, and the speakers will present their cases, and at the end, we will have a Q&A session. If you have any questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. And if you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. Hilary has also launched the OCAD channel on LinkedIn, so you can also check out amazing cases in the quizzes and stay updated about the sessions there. And just a quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material is illegal without the permission from the speaker. And we thank you for your understanding. And with that, before I kick off the session, I want to take a moment to say a big happy birthday to my wonderful co-moderator, Dr. Hilary Humans. Hilary, your dedication, expertise, and kindness inspire all of us. I hope you have an amazing day filled with all the happiness you deserve. Now, Hilary, please kick off the session.
Well, I'm done. That was the highlight of my day. Thank you. Okay. I have the pleasure of introducing my dear friend, Anna Falkowski. She was born in Poland, and actually we met in Poland some years ago when I was faculty at a sports conference. And maybe the highlight was the fact that I met Anna there. And after that, she went to medical school in Dusseldorf in Germany and did her radiology residency in Basel, Switzerland. She has completed multiple fellowships at University of Basel, and then as well as, I had a typo. Anna, your fellowships. I know she did a research fellowship at Ann Arbor, Michigan, and there was another fellowship somewhere else.
Yes, and another fellowship at the University Hospital of Balgras in Zurich.
Okay. And then she stayed on as a faculty member in Balgras. And after that, she has moved her show on the road, and she's now in Winterthur, Switzerland since 2021. She has received numerous awards, including a Certificate of Merit at the RSNA, very impressive. Third prize for Best Oral Presentation at the ESSR, Magna Cum Laude Award for Best Subspecialty Oral Presentation at the ARRS, and a Teacher of the Year in Winterthur, and some fabulous teaching, medical school teaching award in Switzerland. So she's a recognized, wonderful teacher. And now I'm eager to see what you can teach us.
Thank you so much for the kind introduction, dear Hilary. So let's share my screen. So there we go. OCAD sports imaging case. This is a case regarding the knee. I have got no disclosures, and my case is a case of a 16-year-old female which was injured in a sarcoplasty. And so let's start with those sagittal PD fat saturated images of the knee. And as you can appreciate over here, we can already see this bone marrow edema at the sulcus terminalis of the lateral femoral condyle. Going further medially, we can also appreciate this slight bone marrow edema also at the posterior lateral side of the tibial plateau. So basically this pattern of bone injury already makes you think that this is a pivot shift injury. injury. And with a pivot shift injury, we need to take a closer look at the anterior cruciate ligament, which we've got here, and this is torn, of course, in this pivot shift mechanism. Going further medially, we can see that we've got this contractile lesion with the bone marrow edema, the slight bone marrow edema at the periphery of the medial femoral condyle. And going further back and taking a look at the posterior horn of the medial meniscus, we can appreciate that the meniscocapsular junction is quite edematous and it looks a little bit fuzzy and irregular. So this is what I want to focus on now. So basically, is this actually a ramp lesion that we can appreciate over here? So my learning objectives are, we are going to take a look at ramp lesions, their classifications, their interpretation, and pitfalls of ramp lesions. So what is actually the ramp area? For that, we need to take a look at the anatomy. And here you've got a schematic drawing of the meniscus, where we've got with one mark the meniscocapsular junction. And you can see here on the specimen that we've got a high vascularization at this portion. Also, the red zone of the posterior horn of the medial meniscus has got a high vascularity that we can appreciate over here. The red-white zone marked with 3 has got a sparse vascularity, and the white zone shows no vascular portions in it. And therefore, the area 1 and 2 is basically the ramp area that we can appreciate. So the meniscocapsular junction and the red zone. And the ramp lesion is defined as a longitudinal tear at the posterior horn of the medial meniscus, involving 1 or 2 zones of the ramp area. Taking a look in the literature, we can find a little bit of an inconsistency regarding the definition of ramp lesions and an ACL tear. If some papers tend to say that an ACL rupture is just associated with a ramp lesion, and other tends to say that a ramp lesion plus an ACL rupture is basically the ACL rupture is a defining factor for an additional ramp lesion. So the literature is unclear regarding to that. However, what we need to know is that if an ACL rupture is a rest, but the ramp lesion not, this can result in an increased anterior tibial translation and an increased internal rotation, and thus increasing the risk for an ACL reconstruction failure. So, taking a look at the anatomy of the ramp area, we can appreciate here in the schematic drawing and this magnification view of the MR, we can see here the posterior capsule. Here at the superior border marked with the arrow, we can appreciate the meniscocapsular ligament. At the inferior border, we can see the meniscotibial ligament. And this here is the red zone of the posterior horn of the medial meniscus. We've got now 2 classifications regarding ramp lesions. One is by Barnett, the other one is by Greif et al. And both have got 5 types. And the one by Greif is a little bit more going into detail, and I will take a look at all of them with you. So take a look at type 1. This is a lesion at the meniscocapsular ligament, so basically one at the superior border. The type 2 lesion is also located superiorly. It's a partial superior tear of the posterior horn of the medial meniscus. Type 3 lesion is a partial inferior tear that might be just present either at the posterior horn of the medial meniscus or additionally detaching the meniscotibial ligament. A type 4 lesion is a complete tear that might be either a vertical tear of the posterior horn of the medial meniscus or a complete detachment here of the meniscocapsular junction just at the border of the posterior horn of the medial meniscus and the meniscocapsular junction. And a double tear is the type 5 lesion that we can appreciate over here. So do we need to know this classification? Well, I'd like to focus on several things. First of all, type 3 is a hidden lesion. Hidden lesion because it's hard to see it on MR. It's commonly missed and also commonly missed on arthroscopy. So hidden in both modalities of diagnosis. And also what we need to know is that the superior tears, the type 1 and type 2 tears are stable lesions, and the type 3 to type 5 lesions are unstable, so those need to be addressed surgically. So do we need to write down now all these classifications in our reports? I've talked to our clinicians, to our surgeons, and they said that if they would actually use any of those classifications, they would use the first one by Barnett. However, taking a look at their reports of the surgeries, they never write down any of those classification types, but they basically told me that what is most important for them is to know that there is a ramp lesion and where it is located and how long it is, because the longer it is, the more sutures they need to use. And for all of those type 3 to type 5, they would just use the same method, just suturing the tear. So taking a look at some examples of ramp lesion, here you can appreciate the tear that is at the partial inferior side and detaching the meniscotibial ligament. So we've got a type 3 or type 3B lesion. And here we've got this fluid cleft sign where we can see the fluid at the separation of the posterior horn of the medial meniscus and the meniscocapsular junction. So this is a type 4 or type 4B lesion. But how good are we actually in diagnosing those ramp lesions? You can see our sensitivity is just around 71%. We are very specific, but we're not very sensitive. Not sensitive enough, in my opinion. We can increase our sensitivity up to 84% using 3 Tesla imaging. And so 20 to 30% of the ramp lesions are not detected on MR imaging. And the type 3 lesions, we can only appreciate around 50% of them on MRI. So 50% are hidden on MR and 50% or more or less are even hidden on arthroscopy as well. And type 4 lesions, we are way better in diagnosing those. Over 75% are visible on MRI. So is this a ramp lesion? Is this edema in any kind of way indicating a ramp lesion? Let's take a look in studies. Here we've got one study that has taken a look at associated findings. One is the complete fluid hyperintensity between the capsule and the posterior horn of the medial meniscus. So that basically translated means that we've got this fluid cleft sign that is separating the meniscus from the meniscocapsular junction. You can see it was not very sensitive, 57%, but very specific, and it has got a significant it is significantly associated with those ramp lesions on arthroscopy. And also the posterior horn irregularities were significantly associated with those. However, in a different study where they've also taken a look at the same parameters, but also taking a look at the edema of the capsule and the anterior subluxation of the medial meniscus, only this fluid cleft sign showed a significant association with ramp lesions. However, edema at the capsule was not associated, and the sensitivity 33 to 75%, not very helpful. So how is it actually in our case? This was arthroscopically proven not to be a ramp lesion. So the patient was addressed for the anterior cruciate ligament tear with the anterior cruciate ligament reconstruction, and they did not have to suture the posterior horn of the medial meniscus because it was intact. So to conclude, ramp lesions are associated with ACL lesions, can be easily overlooked on MR, and the most sensitive sign for a ramp lesion is a fluid cleft between the meniscus and the meniscocapsular junction. And edema at the meniscocapsular junction can mimic a ramp lesion, but doesn't have to be associated with it. So what do I do in my reports? Do I describe this edema, or do I just leave it out of my report? I certainly describe it. in my report and write down that my interpretation is that there is a sprain of the meniscocapsular junction, just to make my surgeons aware of it, that if they address the ACL and will reconstruct it, that they will take a look at the ramp portion and they will basically probe it with the scope to take a look if there is any instability or not, because I know that there might be a lesion that I could just not see on MR because they are just hidden and not visible enough. However, if they know that there is something wrong, that there is a sprain, they will take a closer look at it. So thank you very much for your attention, and I'm looking forward to the discussion.
Thank you very much, Hannah. Now it's my great pleasure to introduce Juan Pablo Munoz. He's specialized in MSK, a specialized MSK radiologist who completed his fellowship at the prestigious Pontificia Universidad Católica in Chile. He currently serves as a consultant radiologist at the Med Sports Clinic, where he focuses on sports-related injuries and imaging. In addition, he holds the position of head MSK radiologist at Hospital Clínico Félix Bulnes, providing expertise in MSK imaging and leading advancements in the field. Please, Juan Pablo, share your screen.
It's showing all right?
Yes.
Okay. Thank you, Aline, for the kind introduction. And thank you for having me for the second time. Today, I'm going to be sharing with you a lower extremity sports imaging case in this sports session from today. So let's get it. This is an 18-year-old male who is a footballer or soccer player, if you will. And he presented on our emergency department with late onset anterior leg pain after a match. He recalls an anterior blow to the shin, but with no pain after the event, only symptoms appearing 24 hours after that, with progressively increasing pain in the anterior leg. There were no skin-relevant findings during the initial physical examination. So with this, our orthopedic surgeon wanted to rule out traumatic injury, and he requested an X-ray and an ultrasound. These are the initial X-rays and were unremarkable. There were no fractures and soft tissues showed no abnormalities. This is the pain region in the middle third of the leg. Like I said, were unremarkable by X-rays. So we moved on to the ultrasound. This is the anterior compartment of the leg from proximal to distal in grayscale. And at the top, we have mainly the tibialis anterior muscle, which showed normal echo structure. And as we scroll down, we could see that the entire anterior and peroneal compartment showed no relevant abnormalities, but there was this quite striking anterior bowing of the interosseous membrane, apparently due to this expansive lesion coming from the deep posterior compartment. This was present along the entire middle third of the leg until it ran out at the distal third. On the left, we have 4 consecutive slices of that ultrasound, and I'm going to overlay this diagram to give you some references. And of course, I'm going to show you this expansive lesion, apparently from the posterior compartment, with displacement of both the tibialis anterior and the neurovascular bundle. In the upper right corner, we can see the power Doppler interrogation that showed no internal flow within this lesion. In the right bottom corner, we could see that the lesion followed the long axis of the muscle fibers. And also we could see that it showed little to non-acoustic enhancement. So it behaved in a rather solid manner. At this point, we had a mismatch between anterior pain and anterior blow, but posteriorly located imaging findings. So to clear this out, we suggested an MRI. left, we have the T2, and on the right, the DP fat saturated, both in axial. And as I scroll down, we can see mild edema within the tibialis anterior muscle. And once we reach the middle third of the leg, we see this expansile lesion that is in fact coming from the deep posterior compartment. It is within the posterior tibialis muscle, and it is protruding into the anterior compartment. Very similar to what we saw during the ultrasound. Of course, we could also see a fair amount of edema within the remaining portions of the tibialis posterior muscle. A lot of intermuscular edema as well. Let me show you some key images from the studies that I've just shown you. On the left, we have, of course, the ultrasound and what we thought it was anterior bowing of the membrane with displacement of the neurovascular bundle. But in the T2, we could appreciate that the anterior compartment, both anterior and peroneal, showed practically no abnormalities, but we saw this expansile lesion within the tibialis posterior that was protruding into the anterior compartment through a defect in the middle portion of the interosseous membrane, which we didn't see during the ultrasound. This was easier to see in the fat-saturated images, where we can clearly see the torn ends of the middle portion of the interosseous membrane, as well the mass effect over the neurovascular bundle in the anterior compartment. Let me show you some companion images. On the left, three we have already seen, and in the middle of the screen we have the T1 coronal, and on the right, the coronal stir, where we can appreciate some hypointense foci within this lesion, some spots with spontaneously hyperintense T1 signal, and some cystic-like component. All of this consisted with hemorrhage. This was a large hematoma within the tibialis posterior muscle, herniating into the anterior compartment due to a laceration in the middle portion of the interosseous membrane. And this may seem like a super random injury, but trust me, it is not. It is highly specific in this subset of patients, soccer players kicked anterior to the shin. Let me show you. On the left, we have a diagram of the interosseous membrane. And we know all about longitudinal tearing of the membrane in mesonev fractures. Of course, we know a lot about syndesmotic injuries, which blend with the distal portion of the membrane in the distal end. But little do we know about middle portion direct trauma. On the right, we have a diagram of the sagittal stir with the tibialis anterior, of course, in the anterior compartment, and the tibialis posterior, which we must remember is strongly attached to the dorsal surface of the interosseous membrane. So in our patient, what had happened is he had a laceration in the middle portion of the interosseous membrane, which allowed the passage of both the muscle and the hematoma into the anterior compartment. This may be due to force transmission, which initially spared the belly of the tibialis anterior, but pierced the interosseous membrane, allowing the herniation. One thing that I didn't show you from the first ultrasound is the spectral interrogation of the tibialis anterior artery. And we could see along the examination that sometimes the triphasic normal wave was lost due to the appearance of reverse diastolic flow, which is known to be an early sign of compartment syndrome. On upon further investigation, the patient revealed pain with passive motion of the ankle. And on top of that, he suddenly remembered that a couple of years before, he had already been decompressed in the other leg for a very similar phenomenon. So with this information, this patient underwent surgical drainage of the hematoma, and he did just fine. Whenever I talk about compartment syndrome, I think of this slide, because we have real clear cutoff values of CK levels when we have rhabdomyolysis. But before we have frank necrosis, there's this gray area where clinical findings may not necessarily match CK levels, and is, in my opinion, in this window where imaging may play a key role, both in MRI and ultrasound, detecting early signs of compartment syndrome. I see a lot of professional football players, and this is another case I saw a couple months ago. This, on the left, we can see the bowing of the interosseous membrane, and on the right, the normal leg with no alterations in the anterior compartment. This is the MRI from that patient, and we can see the exact same hematoma within the tibialis posterior, the herniation into the anterior compartment, and of course, the perforation of the central portion of the interosseous membrane. And this has been described before. Traumatic rupture of the interosseous membrane, a rare cause of acute lower pain in two soccer players kicked in the anterior shin. The exact same mechanism and the exact same clinical and imaging findings of my two patients. This is from 2022 skeletal radiology. Let me show you their original pictures. We can see that the imaging findings are quite the same. My pictures, I think, are nicer, but whatever. The yellow arrow is pointing out to the interosseous membrane and the hematoma, and the red arrow points to the neurovascular bundle. If you look to the right bottom image, you can see that they attempted percutaneous drainage of the hematoma, which in our patient was not feasible, mainly because it was mostly clots that won't come out even with large bore needles, so we didn't try that. With that, I'll leave you with my take-home points from these cases. This is a highly specific, unpredictable pattern of injury in soccer players. This is not a random hematoma that just happened. When you have anterior trauma, think posterior compartment. That's the way to pick up these lesions. Otherwise, you can run over them and just miss them. And finally, expect potential complications. One of my patients, and as well one of the patients in the review I just shown you, presented with acute compartment syndrome, or at least early signs of it. So with that, I thank you once again for the kind invitation, and thank you all for your attention.
Hello again. This is just so good. Now I have the pleasure of introducing another great friend of mine, Mark Cresswell, who's on faculty at the University of British Columbia in Vancouver. He's the director of the St. Paul's Hospital Musculoskeletal Fellowship with a specialty interest in imaging and treating sports injuries as part of University of British Columbia's academic complex, where he's clinical professor. And in addition, is the outgoing director of the RSNA Global Learning Center in Stellenbosch, South Africa. Mark is actively involved in both the ISS and Society of Skeletal Radiology. He did his undergraduate training in anthropology and medicine in South Africa, initially specializing in anesthesia, including pain management, before moving to do his radiology residency at St. Mary's Hospital in London and musculoskeletal fellowship in Oxford, UK. He moved to Vancouver in 2007 and had great fun co-managing imaging at the Vancouver Olympic and Paralympic Games in 2010. He still likes to get involved in real medicine and has been actively involved with Médecins Sans Frontières, I butchered that, for 20 years and works at Whistler on ski patrol. Okay, Mark, I hope you can share your screen. Turn your audio on.
Muted. He's muted. He's asking me to unmute him.
Oh.
Milene, você pode desmutar o Mark, por favor? Mark just asked the secretary of our society to unmute you.
Fate.
God, I think you guys can hear me. Is that correct? Thank you very much for the invitation. Sorry, my voice is going. It was a long week on call, and I managed to catch a lurgy. Happy birthday to Hillary. Linda Probin's not with us at the moment, but it's Linda's birthday as well. And I'm not sure if we should all unmute and sing happy birthday. but happy birthday, the intentions are good. I'll be speaking on gripping sports, particularly trigger fingers and triggers, and I'll start as follows. So just quickly, I've done some speaking for Philips Healthcare and work at UBC. So most sports which have a ball, other than the kicking sports, which we've just dealt with in the last one, thanks Juan, as soon as you hold a ball or grip a club, batting, holding a club in golf, rock climbing, your grip is extremely important. So anything that interferes with the smooth translation of your tendons is an utter disaster. So we're going to be looking at tendinopathy, particularly where there's focal swelling of a tendon, masses, inflammatory arthropathies, which can cause synechia with those tendons, and foreign bodies. So I'll give you this one. So the first patient is actually one of our senior heart transplant surgeons. They presented with an inability to control their fine finger coordination and had massive triggers of all their fingers. There was a gradual onset. It was getting progressively worse, and they were now dropping instruments, which, as you can see from the Weird Al Yankovic parody on Like a Virgin from Madonna, he kept dropping things and it wasn't great. So this is what we saw when we first ultrasounded him. This is with an open hand in the carpal tunnel, and with a clenched fist, it drew this mass through the carpal tunnel. So we saw on the longitudinal view this large, can you see my pointer at all? My pointer is visible, good.
Yes.
This large mass on the flexor tendons, which when they made a clenched fist, drew the mass proximally into the carpal tunnel. So here we can see a live video of that, and you can see the mass in transverse and longitudinal popping through the carpal tunnel and having this mass triggering event of all the fingers, particularly the middle fingers which they use to grip their instruments. We did an MRI, and we've got this mass here that's located between the third and fourth Pulleys fingers, and you can see it's quite a large mass. This was particularly concerning for us, given that we didn't know what the mass was. We didn't know whether it was a sarcoma. And the compartment is the entire tendon sheath. So to treat the sarcoma, it would mean a forearm amputation or mid-forearm amputation. So we did a cine of the MRI, so you can see the mass popping through, and you can see the trigger as it pops back and forth between the carpal tunnel. As that mass passes through the tendon sheath and the retinaculum, it forms a bulging mass and then pops through as a release of that pent-up energy. So here we can see it all at once. You can see the whole lot going together. They're nice images, but I think we've seen those. I'll skip through. And so how do we make sense of trigger finger and trigger fingers, in this case, pathology? And there's a couple of different classic areas. So it's all about location, location, location. And literally with our fingers, we can follow the tendons, the strings like a marionette that help move our fingers around to the muscles in the forearm. So the locations are usually the A1 pulley of the index finger, A2 pulley, but it can be any finger. Anywhere along the thumb is an opposable thumb. It's really important to us as humans. So if they get a triggering here through the pulley there, the carpal tunnel, as in the case we've just looked at, there's a whole series of retinacular through all 6 extensor compartments of the dorsal aspect of the wrist, and we'll just quickly skip through those. So we've got the first extensor compartment, and if that retinacular thickening occurs, we call that, and I'm going to macerate the French of this, so please forgive me, those of you who speak French. I'll do it the South African way. We call it Dequevans. I'm sure it's called Dequevant or something spectacular. So this gets thickened and traps these tendons. Extensor compartment 2 is not usually a problem, but extensor compartment 3 is a very tight single pulley tendon, and because it's a pulley going around a listus tubercle, which acts as a fulcrum, it can also get focal tendinopathy of the pulley, which leads to problems. So here we can see an ultrasound, a panoramic view of all the different tendons, and you can see the small sulcus that arises at each one of these compartments. So here we have Lister's tubercle, the extensor pollicis longus tendon, and it comes around Lister's tubercle, using it as a fulcrum through its retinaculum, which will act as a pulley, and we end up, I'm just going to go through that, it changes direction, and any swelling as that tendon rubs over around the Lister's tubercle can result in focal swelling of that tendon, and you get triggering of the thumb, with the extension of the thumb being affected. Remember that triggering can be either flexion or extension, depending on which tendon is involved. In this particular case, you can see an MRI. You can see the crossover, and this was an arthrogram where the contrast leaked into the tendon sheaths, which outlines them very nicely, so you can see the contrast. And that's Lister's tubercle acting as a pulley. I'm going to skip through that. Just when we do get that, you normally get ruptures at this location. So it's not just triggering. And the tendon repair, they draw this back out again. The tendon repair may also form a thickened nodule within the tendon, which can act as a pulley. Dequebain's tenosynovitis, here you can see the inflammatory component on a SPECT CT. On MRI, you can see the thickened rind, often thickened inflamed tendons as well, and this leads to quite stiff movement of the thumb with triggering. Remember that any sclerosing or inflammatory synovitis, you get this nodular synovial thickening around the tendons. They can form synechia with the tendons so that there's contact instead of a slidey layer with hyaluronic acid, and that you've ended up with this nodular thickening, which can either cause frank stenosis or indeed tethering to the subjacent tendon. I'm going to just quickly skip through the nerves, but what we're getting at here is that we have all these tunnels, these retinacular, which the nerves and tendons go through. When you end up with masses going through these things, triggering, they're often accompanied by compression, focal compression of the nerve at that location. And so we can end up with masses going through tight spaces for nerves. I'm going to quickly skip through that. Ganglions within the space can have a similar effect. And I thought I deleted some of this, sorry. This is just a fibrolipomatous hamartoma of the median nerve. Remember that you get fatty thickening of the nerve, and in this case, the nerve is now compressing the adjacent tendons. This is low-lying myotendinous junction. Occasionally we have a very low-lying muscle, and more commonly an interosseous, a lumbrical muscle belly attached to the tendon, which passes back through the tendon. So in the open hand position, you can see this muscle belly is just coming into the compression of the carpal tunnel retinaculum. And with clenched fists, it's drawn proximally into and through the carpal tunnel. And you can see the spacing out of these tendons in this position. You can watch that dynamically on ultrasound, and you can see as that muscle gets drawn through the carpal tunnel, you get the similar effect as that surgeon with the fibrous mass. Incidentally, just so you all feel relieved, it turned out to be a benign fibrous mass within his tendon sheath, and he was all good to go, so there was no amputation. I'm going to just skip through that. Don't forget, people fracture their wrists regularly, so we've got other bits and pieces in there, including metal wear, so the volar plate on them can affect the tendons. You can get tethering and subluxation of the tendons over these volar plates because they stand proud. Here you can see the tendon riding over this plate, which stands proud relative to the volar aspect of the radius. So that's quite a nice demonstration, and it can sublux to one side. Conditions you can see here on a rheumatoid hand, the hypoechoic, the dark areas here, you can see this nodular thickening that follows the entire length of this tendon, so you get areas of synechia and tethering, and you can see the same thing in a contrast enhanced MRI when we line it up to the tendon itself. And color Doppler obviously can demonstrate hyperemia. And lastly, rock climbers' fingers. Remember that the rock climbers need to grip the rock. They have various hand positions, not just gripping and compressing. They form fists and cracks, get their fingers right into it, and obviously come out with injuries. I'll skip that just to point out the A1 pulley. If this is thickened, this is probably one of the most common areas for a triggering of the finger, where you get focal fusiform thickening of the tendon. You'll see a little loss of um, what you call it, the normal fibrillous structure. And if you hold your finger and you, so that the middle phalanx is secure, and you just move the DIPJ, you'll move the profunda tendon, the deep tendon, in isolation. If you bend the finger at the PIPJ, you'll get both tendons moving. So you can isolate which tendon is the tendon at fault. Remember, the pulleys are super important to keep the mechanical advantage of our fingers and get that tendon tacked down next to the bone. So yeah, this is, by the way, when the rock climbers pop their pulleys, they end up with the taping, which is simply recreating those pulleys with tape to reconstruct the tethering of the tendon back down towards the bone, instead of the bowstringing, which we can see. From a constriction point of view, remember that when they do pulley repairs, they use tendons, tendon graft. Often the plantaris tendon is used, or the palmaris longus, and these can be thickened and scarred and also cause tethering of the subjacent tendon. This is just a quick thing of plantaris and how to look for it if you want to help your surgeon find where to get their spare bits, their spare parts for the surgery. So when you get pulley tears, they get thickening of this pulley over here, and that can clamp down on the tendon. This happens to be an A2 pulley, but it can be any one of these pulleys, can result in a similar effect. Just so you know, when you're trying to do an ultrasound, it's very useful to use one of these wash basins that your granny has in the basin in the sink. Fill it with water, leave it for a bit because there's micro bubbles you can't actually see. Pop the probe in with the whole hand, and then you can watch it move dynamically, particularly with a hockey stick you can get around the fingers. So this is very useful to help us visualize with ultrasound and dynamically watch it, because it's really tricky to keep the jelly in the right place while you're doing that technique. And gratuitous MRI with a bowstringing. And a similar case here with a local rock climber. She's a rock climbing champion. You can see the graft. You can see how thick that reconstructed pulley is once they put tendon graft in there. In the interest of time, I think my time's up at this point. But thank you very much. And yeah, Aileen, thanks a lot for the invite.
Thank you, Mark. Beautiful images. Hillary, you asked something in the chat for Anna.
Yes, Anna. So I don't know if you saw my question. It seems that we might always miss the type 3 ramp lesion. And if that's true, is it reasonable to assume that they're always looking for ramp lesions, whether or not we report them? And
Well, oh, sorry.
yeah. And I mean, Dr. Sarah, I think that's her. Dr. Sarah basically asked the same question for me. Since the periphery is so well vascularized, why doesn't these ramp lesions, why don't the ramp lesions just heal without surgical suturing?
Yeah. So to address the first question, I know that my orthopedic surgeons, every time when they perform an arthroscopy of the knee, they always search for a ramp lesion. But I know that unfortunately this is not the case in every single hospital, because to look for ramp lesions, you either need a probe, you need to scope also from the posterior side, or you need to put your scope through the intercondylar notch to basically see the posterior horn of the medial meniscus and then probe on it. And if you do not do that, then you will miss the ramp lesions totally on arthroscopy. And so my surgeons always tend to do it, no matter what I report. But they are always grateful if I make them already aware of it, that there is a ramp lesion or not. Regarding the second question, which was why do ramp lesions not heal if they're in an area that is highly vascularized? The problem is that there is a high mobility in that area. So basically, the moment you move your knee, this ramp lesion tends to open up, and therefore it doesn't matter that you've got high blood supply over there. This tear will always open up again. So basically, you need to suture it. Like you would basically try to support fracture healing by putting on a plate. Here you support healing of the meniscus by putting in a suture, and then the vascularization can help to make it heal on its own later on. And while the white zone tears over there, because there is no vascularity over there, a suture would not help at all, because this is not sufficient enough. The body needs to heal the meniscus, and since there is no vascularization, they would basically resect this portion at the white zone if there is a tear over there.
Sure. Should I ask Mark my question?
Yeah, sure.
Okay, Mark.
Hi.
This is just actually a personal practice question, because I know we work with ultrasound techs, and they have been instructed to measure the finger pulleys both anteriorly and bilaterally. And I asked them why they do this, because it seems to me the lateral measurements won't be accurate because there's, dropout. But, when you showed the images, I think that were post-surgical, obviously it was kind of circumferentially thickened. But when you measure pulley thickness, do you just do it anteriorly, or do you measure it medial and laterally?
Just when you said bilaterally, I think you mean like radial and ulnar side of the same point. Yeah. So I do, by the way, just check bilaterally to see how big the opposite one is, because some people, like builders and plumbers and electricians, now they just use electrical drills and things, but they used to use screwdrivers, and when they grip, you can just get thickening of things generally. In the imaging you're describing with the dropout is if you just have it, I'm going to use my phone as the probe. If you just have the probe like this on the finger, you end up, I'm going to come a little closer. You like this, but you can remember, you can bring the probe so that it evaluates. So it's when you store images, you may send a few select images to PACS, but what you've done in your mind is build up the whole tendon, the whole pulley, by coming from a radial side across the top to the volar side, and then moving to the ulnar side of the thing and evaluating the whole thing. To me, it doesn't really matter where it's thickened. If it's thickened and it's leaving, so I go longitudinally and I'm flexing and extending the finger, watching whether the tendon is focally stopped or not. Because if I can see it bulging up and buckling, trying to get through, that there's a problem. So you're going to do a pulley release if that pulley, doesn't matter where it's thickened. So it's nice to know, and I put it in a report and I'd always describe it, but it actually doesn't matter if you've got tethering at a particular pulley.
Okay, that's great advice. Thank you.
There's one more question here in the chat. Anna, do you think that the word fraying is an appropriate term to describe the equivocal ramp 3 lesion, or do you say meniscocapsular sprain?
No. So for meniscocapsular sprain, I would only describe if I just see an edema at the meniscocapsular junction, but without any tearing, basically the case that I've showed you from that 16-year-old female. But if I see a tear at the partial inferior side of the medial meniscus, basically the one example that I showed you, then I describe it as a ramp lesion, which is just at the partial inferior side. So I describe it as a tear of the meniscus at that portion, but not as a sprain. You're welcome.
Okay, I don't see any more questions. So thank you all for tuning in today. We'll be taking a break in December, but mark your calendars. The next session will be on January 24th in 2025. We're excited. Next year, we're excited to introduce a new session format, pairing a radiologist with an orthopedic surgeon to discuss cases. And we can't wait to see you back in January. Until then, happy holidays, and thank you for being part of our growing community. Thank you.
you.
Bye-bye.
Very much.
Thank you for the birthday wishes.
Happy
Thank you.
birthday.
Bye.
Sorry about the croaky voice. I was just trying to get a husky voice for you, Hillary.
I love it. You know I do.
Okay.